All right. Let's start. I want to thank all my colleagues for their support. Dr. Graham, thank you so much. And I want to thank Sylvia, Roy, Joseph, Ravi, Sriram, and my mentor, John Stroline. And these are my acknowledgements. And this is a story of a 70-year-old, and she was referred to me for a large polyp resection. And Dr. Graham was saying about, seeing the patient before they come for colonoscopy. I think it's very important, especially when you have a complicated problem where you have to think through and manage the patient with the help of everybody else that involved in her care. So she's 70-year-old, and she lives about an hour away from us. And she wanted to actually, she preferred to do the visit on the video. So we did a video visit with her and her husband. And she has a history of a myeloma and is currently on active therapy. And she had a hysterectomy, bilateral salpingo-oophorectomy, cholecystectomy, appendectomy, and also had a history of diverticulitis in the past. For the last year or two, actually, she has had multiple vertebroplasties for vertebral fractures related to her underlying disease, as well as and therapy related to that. So she had a colonoscopy in the spring of 2021. And one of my colleagues did the procedure, and I'm going to go over the findings in the next slide. So to give you a little bit of a history of a myeloma, I thought that, okay, if I'm seeing her, and maybe it will help me to read a little more about myeloma, so, and also help you. 5 years ago, she presented with vertebral fractures and back pain, and that led to this diagnosis of myeloma. And she was treated with Velcade, that is bortezomib, which is a proteasome inhibitor, that allows the cells to die because it doesn't, the immunoglobulins accumulate as a machinery to destroy the immunoglobulins gets disrupted. And then dexamethasone and the Revlimid, that is linalool. It's a thalidomide analog, that is a lenalidomide, and it has multiple actions on myeloma cells. They followed the same protocol that is currently the treatment now. I think if somebody is 70 or below, they treat them and then they put them to autologous stem cell transplant after melphalan therapy. And she had a partial remission, so she was put on some maintenance therapy. And then for the last 1 year, she has been on this carfilzomib that is similar to the bortezomib, that actually interferes with the proteasome activity, cyclophosphamide and dexamethasone. And as you can see here, right, she had myeloma, which gives lots of problems with bone disease, and then the steroids also aggravate. And for the last 1 year, she had lots of kyphoplasty stuff. So the spring colonoscopy, it's interesting, right? She had a normal colonoscopy 10 years ago. And in spring, she had a second colonoscopy. And she had lots of polyps. And my colleague did a good job removing a lot of polyps. As you can see, she found this 30-millimeter polyp in the cecum. And she felt that it's better to defer resection and get it done at the main center. ascending colon, 15 millimeter hot snare, 3 millimeter polyp, jumbo biopsy, transverse colon, 5 and 3 millimeters cold snare, descending colon, again, 5 millimeter cold snare, sigmoid colon, again, 5 millimeter, 4 millimeter cold snare and cold biopsy. As you can see, my colleague actually worked very hard and took care of a lot of polyps that could be done. And the path revealed multiple tubular adenomas, and the larger ones turned out to be tubulovillous adenomas. Fortunately, despite her underlying medical problems with myeloma on active therapy, she did well. She didn't have any complications. And this is the cecal polyp, as you can see here. This is a cecal polyp. This is another polyp in the ascending colon that she has actually removed. And you can see this is the cecal polyp. And so when I saw her, it took almost an hour to sit down and talk to them. And this is what I felt. She is in her 70s, myeloma under active therapy, received stem cell transplant with an alkylating agent, melphalan, and is currently immunosuppressed. And she had one bout of severe pneumocystis pneumonia last year that had put her down for almost a month in the hospital. And she also had a herpes zoster. And she is currently, when I saw her, I think in summer, she was undergoing restaging of the myeloma. And my impression was, given these features that I'm dealing with, large polyp in the cecum, a lot of chemotherapy, a lot of steroids, and frail health, I felt that she is very high risk for bleeding and perforation, and also high risk for surgery. And if a complication were to happen, I thought that we may lose her. So I reached out to the oncology team and actually talked to 2 oncologists who are managing her. And they felt that, hey, why don't you wait and see? Let us restage her. And depending upon the restaging, we can decide what to do next. So she had restaging, and the oncologist felt that she's doing reasonably well, and they felt that they're going to hold off her treatment and wanted me to proceed with colonoscopy. So I told you a very long story, and why don't I stop here and let us see and hear any comments. Roy, Selvi, or maybe let's wait just 1 second. Let's give it to Zubair. Zubair, Zubair is still fresh with the internal medicine. He was a chief resident. He's one of our senior fellows. Zubair, okay, you heard the story, or you want me to repeat it?
No, sir, I heard the story.
All right, I want to hear your thoughts. As a chief resident, think that I'm your intern.
I think it's a challenging case because of the comorbid conditions. Definitely, when you are like approaching such kind of a case, you have to take into consideration like although the polyp is big, but the time it will take to turn into malignancy whether that time period, we have to take into consideration that that time period is going to be long enough, or the like the with the comorbid conditions, what's the prognosis of the patient. I think that's what the oncologist wanted to achieve with restaging as well. To I believe so. They wanted to see, like, with the restaging, they may want to see the long-term prognosis of the patient, because if the patient has enough time for this, then definitely um, we can consider resection of the polyp. But otherwise, I think attempting such a high risk procedure would be a kind of challenging.
Yeah, one thing that has changed in myeloma, for the sake of my colleagues, I've spent quite a bit of time for the last 2 days reading a lot of editorials published in the New England Journal. In the late 1990s, thalidomide made a huge impact in terms of prolonging the survival. And then the early 2000s, the thalidomide analog, that is Revlimid, that is lenalidomide, and then the proteasome inhibitor, bortezomib. Bortezomib is Velcade, right? And those things have actually made a huge impact in terms of prolonging the survival. And this couple of last 3-4 years, there was a monoclonal antibody for, I think, CD38 that specifically targets the cells, that has been shown to have a huge game changer. It's interesting to see that. The reason I'm bringing this is when I spoke with the oncologist, he said she will certainly have 5 years span before they need to add some other newer therapies. So let me ask Dr. Graham what he would do.
I would kneel down at night and thank God that you were here to take care of this bone.
I'm struggling here, sir. That's okay. All right. Let me hear Ravi or Roy, Sylvia. Yeah, because it's very important for us. I don't want trainees to think that, okay, polyp is a polyp, let's go and cut it, right? It's at the end of the day, our goal is to take care of the patient.
Maybe I can have a short comment.
Yeah.
I fully agree with Zober's reasoning on this case. Can we have a closer look to the lesion? Because it appears, I have seen only one pictures, and it seems to be a large pedunculated or sessile polyp, but I didn't see any signs. It's on the left side. Do we have more pictures, or this is the only picture?
These are the 3 pictures that are there in the chart
Okay.
that I picked up related to this polyp.
Yes, this actually underlines the importance of good photo documentation when referring such cases, because the lesion doesn't look to me malignant, but I don't know. I would like to take a closer look using image-enhanced endoscopy, and based on the risk of the lesion to contain submucosal invasion, I will discuss with the patient whether this lesion should be removed or not, because definitely, even if her multiple myeloma is in remission right now, she has a very high risk of complications, as you have already mentioned, risk of related to the immunosuppressive therapy, corticosteroids, use of corticosteroids, age-related, and other comorbidities. So I think that the patient-related risk is much higher than the lesion risk to contain submucosal invasion.
Right. So one other thing is I want to actually use a pen, use a laser pointer. Okay. When I saw this picture, and I thought that this will be easy to cut, although the polyp was head is big here. There are two lobules. As long as we take a larger snare and able to go, and I was looking at the stalk, and as you can see, the stalk comes from here. It comes down, right? And this is the other wall. And this is the amount of stock to cut, probably inject a little bit to get some safety margin. So looking at it, I thought that, okay, we should be able to cut. And that's the reason why we went to talk with the oncologist and made the arrangements, held our chemotherapy cycle, and started on this set her up for colonoscopy. So let me take you to the case. She also, because of all the vertebral fracture issues, kyphoplasties, a lot of back pain, requiring a lot of narcotics. We actually spent quite a bit of time with her in terms of how to do her prep, and given the issues that she has been dealt with, she has done an amazing job doing the prep and get her prep done. And for the sake of fellows, I want to share a couple of things. Even though you know the case well, before you start your procedure, or probably preferable at the bedside, I usually open up the endoscopy report so that we refresh our own mind and also refresh the mind of the patient and the patient's relative. In this case, I opened the endoscopy report from the previous procedure, sat down with the patient and her husband, and I went over it. And I basically said that, okay, we should be able to take care now that we have all planned the procedure well, chemotherapy, holding the chemotherapy, etc. Interestingly, one of the things that we are doing is, we are doing these virtual visits, and virtual visits, we do miss the opportunity to see the patient. And Dr. Graham has been pointing that out earlier. That is important because when I saw her for the first time physically, one thing she told me was she has a very bad back problem with kyphosis, and it is hard for her to lie flat, and she has to be kept at about 45 degrees angle. And knowing those details, maybe it would help you plan a little bit better rather than having a surprise. So I just want to make that comment. And you also have to keep in mind that she had lots of surgeries. She had pelvic surgery, hysterectomy, she had a cholecystectomy, and she had an appendectomy, and she had acute diverticulitis in the past. And constipation, you can see some melanosis there. It was a little bit tough to get in there, but we were able to get in. And it was a little bit tough to maintain the position of the scope. And she has done a good job with her prep, with a little bit of stool. This is a stool that you could always clear that out. And this is what we see. Zubair, any comments on here?
Yeah, means I'm not able to see the clearly, but as comparing with the previous picture, it looks like to be the same morphology, right, as the previous picture. Yeah, there is no further growth, it seems to be.
All right. So the first thing we did was it's important to clear it off. So we decided to just put some water and clear the polyp, clear the residual stool, and so any comments now, Zubair, Ravi?
Mhm.
So here it looks like to be a pedunculated polyp with a stalk.
Yes, it's better.
Mm-hmm.
Raju?
Yeah, Sylvie,
It's
go ahead.
Selvi, sorry, I joined a couple minutes late, so my apologies to everyone. Had this been biopsied before? Do we know that this is in the adenoma family?
Yes, yes, it is. It's a tubular. All of them were adenomas and tubular villus adenomas.
Okay, thanks.
And was it a high-grade dysplasia? This
No,
lesion?
no dysplasia.
Okay, so adenoma.
Right. So now you actually see a little bit of a better cecum now. There's another small polyp there.
Mhm.
One of the things that I've been trying to figure out is define the polyp a little bit better, define the stalk a little bit better. And one thing that occurred to me was I'm looking at a polyp that is a little bit bigger for sure than before. And I was assessing the size of the stalk because I went there thinking that it will be a simple, not simple, it will be a relatively straightforward heart snare resection. And when I was looking at the polyp size, the head was bigger than before. And as I was looking at the stalk, as you can see, I'm taking lots of pictures of the stalk and then going from the left to right. And also not only evaluating the breadth of the stalk, but also the total thickness of the stalk. The reason I'm making this comment about the size of the stalk is in pedunculated polyps, people have shown that they tend to have not one, but multiple feeding arteries. And that's the only way the polyp can become that big. And the second one is the size of the arteries can also become much larger. And that was one thing that was going through my mind. So now that you see this, what do you guys do?
So
Go ahead.
Raju,
Yeah.
just given the number of comorbidities that she has, her age, the size of the lesion and the location, I'm wondering if we should start planning for a polyloop in resecting this lesion.
Yes, yes. Yeah. So I'm glad that you brought that comment up about polyloop. That was what was going on in my mind. But when you are applying a polyloop, especially when you have two big heads, I've run into problems because you can't see the polyloop on the other side of the polyp. And when you try to close, you end up closing onto one head. And this is a polyp that is not safe to cut. The polyp head, chop, and then try to cut the stalk. If you look at Dr. Jerome Wei's textbook for large polyp resections, he has shown that, okay, if the polyp head is too big, you can cut the head. And when you, the times that I did, once you cut one head, the vessel that's feeding that, if it starts bleeding, it's very hard to find that vessel in the midst of this polyp tissue. So I try not to do, if I can cut the stalk, I will be happy, and then do the cut of the stalk. Roy, I think Roy is gone. Yeah. Ravi, what will you do?
I think this one is a very challenging case. One of the concern here is when we see such large pedunculated polyps with many heads, to get a complete assessment of all the heads and in between the polyps can sometimes be trickier, because as soon as the scope gets past the polyp, they tend to bleed with contact and so on. The other concern is when we encounter such huge polyps with many heads, the likelihood of them having an advanced pathology is also going to be slightly higher compared to a simple polyp. In this case, the stalk looks thicker. It's more than at least 5 millimeters. I think it's around a centimeter. And that by itself gives a clue that there are going to be so many big blood vessels running in. So whenever we want to cut this, I would rather try to constrict those blood vessels before I apply a cautery. My preference in this case would still be let the polyp float. I will put a lot of water in the cecum, and the position is fairly nice. We are letting it hang down, and with a lot of water in the cecum, it just floats around and makes it easy to put an endoloop as close as possible towards the base of the colon. Uh, we One, as you mentioned, one critical aspect is to make sure that the endoloop is not getting stuck between the heads. If possible, we will have to make sure the entire loop comes to the base of the stalk, such that it's not trapping any head. So that would be my choice. I would try to endoloop first and then snare cautery.
Yeah, that's good. I think that's a good game plan. One other, let me ask Sylvia to comment, and then Nizam to share his thoughts. Nizam is here.
I think that I would also go for the endoloop. I think that that's the safest solution in this case. I agree with Ravi. An alternative would be to the polyp is very well visualized. We can clearly identify the stalk, and this is the best position. I could also inject adrenaline into the head and into the stalk, and try to resect with a regular snare, with a large snare.
Yeah. All right, that's good.
So we list the solutions, and I hope that through discussion we will come up with the best solution in this case.
True,
So
for sure.
maybe
Right.
more solutions, because Selvi said a polyloop. We had polyloop, endoloop, injection followed by snare, hot snare. So I think these are the possible solutions.
Okay. Nizam?
Well, I think I will inject the base to have some tamponade, and then I will hot snare it. Either if I can get the whole lesion with a large snare, that would be my preference. If not, I would be willing to do, because it's a multilobulated polyp, so, one or two of the lobules at a time, and then finish it up at the base. And then perhaps I have to use later on some clip or other devices as a tamponade.
All right. Jaydesh, what do you think?
So yeah, I agree with this endo loop. The other alternative described in the literature recently is this just application of clips to the stalk circumferentially, and then go for the hot snare resection. But we need to, like Ravi said, we need to reduce the blood flow to the head before resecting. That will be the key position. The other thing to note in this particular case is that the position doesn't seem to be stable, and you mentioned that as well. And we cannot change the patient's position since he has a lot of fractures.
Right.
And so on. So that's another thing.
Right. I see Paulo here. If Paulo wants to make a comment, and then I'll share with you what we did. All right. I'm going to use a pen. So you all made very interesting and very useful observations. One is the polyp has multiple lobulations, right? Yeah, we all agree on that, right? And the second one is, let's see. Let me just change the color of the screen. Okay. And if you look at the wall, that's the inner wall of the cecum, right? You agree with that? Ravi?
Yes, agree.
Right.
Right.
And then you have so if you cut, that's your area that you need to cut. And that's a large cut. And you have to keep in mind, and if you listen to Jerry Way's talks, cecum is about 3 to 5 millimeters in thickness. 5 millimeters thick is somebody who's in great health, a male with a lot of muscle mass. In her case, who is very frail and with a lot of, her cecum is probably not going to be 5 millimeters, probably 3 millimeters, right? And to cut this, you'll be using with a hot snare, a lot of current. And you will be afraid to cut because of big feeding vessels, And I have one video where we cut and that showed multiple feeding vessels. And those feeding vessels will be at least 2 to 3 millimeters in size. And in order to not have bleeding, you probably have to use coagulation current, and the amount of deep thermal injury will be quite a bit. right? You agree with that?
Yes.
And thinking through, and then here is a lady who had bone marrow ablative therapy with an alkylating agent in the past. She has been on dexamethasone for the last 2 years, and she's thin. Basically, you could feel her bones when you touch her arm. So taking those things in mind, I basically backed off. I did not cut it. And I explained to them, to the family, I said, when I look back at her pictures, when I looked at this picture, I thought it was relatively easy to cut, right? You agree with that, right?
Mhm.
Right. But when I look at this picture, I felt that this is something that has changed. And if in case I ended up with a big perf or a big bleed that I could not control, she doesn't have enough reserve, like a young, healthy person, to come out of that complication. So I explained to them and I said, I'm quite disappointed that I couldn't help, but we have not lost anything by backing up. I think it's, and that is the decision I made, and I hope I made the right decision for her. And I'm going to, the options for her are basically, we need to go back to the table and ask ourselves, do we leave things as they are and see how things pan out with her myeloma, and whether this polyp is going to become cancer and become an issue, or whether we should jump and get this thing taken care, whether with a laparoscopic colectomy or consider doing an ESD. In terms of resection, I felt that if you do ESD, you're cutting small areas and you'll find a blood vessel, you will control that bleeding vessel and then keep cutting. It is a little more controlled if you have a good ESD person that can do this. And I actually spoke with the family just this weekend, giving them the options of both surgery and ESD, and wanted her to see both laparoscopic surgeon and an ESD colleague of mine, Dr. Phil G. And I'm actually going to send them a video of what I saw so that they can actually look at it and then make a game plan to take care of her. And I also told, for the sake of trainees here, once you take care of a patient, once you decide that you couldn't do, or for whatever reason you back off, it's important to stay engaged with the patient. So I told the patient that once you see both of them, I said, this is just an exploratory phase, trying to learn about options, the pros and cons, and then we will sit down and I'll try to help you think through this process.
May I ask a question?
Yes, please.
Regarding the multiple myeloma. I'm not a specialist in this field, and I was wondering whether the hematologist made any statement regarding the life expectancy of this case, because getting back to our previous discussion, if this lesion is an adenoma, then worst case scenario, let's say it's not an adenoma, it's high grade dysplasia, then it will still take 3 to 5 years before it becomes cancer. So
Right.
if it's a high-grade dysplasia, and if her life expectancy would be less than 5 years, then I think it would be an additional argument not to resect it. But I'm not sure what
Right.
the hematologist.
I'm glad that you brought this thing up, and that was the point that was I was debating before taking her and scheduling her for this procedure. And it took almost 2 to 3 months for us to get back together. And I specifically asked them what is the expected lifespan, and they said he didn't answer the question. You know, he said she can go on this treatment for 5 years before we need to change the treatment plan.
Okay.
So I felt that, okay, 5 years. And then plus, if I had seen this lesion with the details that I'm presenting to you, probably I would not even done the colonoscopy to resect this. And because I know that that's a lesion that I cannot safely resect. On the other hand, when I saw the lesion that we all saw in that report, that is a lesion I could safely cut, and if there were to be a problem, I could safely manage. For this one, I felt that it will take a lot of heat, and even if you are able to close the defect and all those things, the deep thermal injury, your clips may look great, but they will fall apart pretty quickly, and probably will end up with either an acute perforation during the procedure. If not, there's a very high chance that there's going to be a delayed perf. And those things are a mess in an immunocompromised patient.
And the lesion is proximally located, so in case of rebleeding, you will have to go all the way around again.
Right.
So it would be, would it be a sigmoid polyp? Then it would be much easier to access it in case of rebleeding.
Right. Any other thoughts?
Dr. Raju, how about just endoloop application and leave it without resection? If we just apply endoloop and.
So yeah, you could consider that. If you want to do an endoloop, there are a couple of things I want to suggest. I've done a few, maybe one or two cases where I've done applied endoloop and let it fall off. It's like a lipoma loop ligation. When you do that, you don't want to just apply the loop, tighten it, and then release it, right? That's what we do when we apply the loop. So if you want to achieve the benefit of an endoloop ligation of the blood vessels, I would tighten the loop and sit there for about 5 minutes. I mean, literally 5 minutes. I sit there with the loop tightened without releasing it for 5 minutes, hoping that 5 minutes of strangulation will cut off the blood vessels, and then release it. That's one technique. In this case, I felt that the loop may not be able to get around that big polyp to be able to get to the base. That's one reason, right? I spent a lot of time trying to figure out, the thickness of the base, the heads, and all those things. And I felt that, okay, this is not a case where I could safely apply a loop and be able to take care of the problem. Although I think my colleague, anybody who's doing ESD could do this. Still, the concern would be how the wound would heal. There's a difference between ESD of a flat lesion and an ESD of a big sessile or semi-pedunculated polyp. We should not forget that concept. If it is a flat lesion, maybe a couple of millimeters thickness, they don't have big feeding vessels. But when you have a big pedunculated polyp, they will have big feeding vessels. And the question is, how much of heat do we need to control the bleeding from those vessels and seal those vessels and be reassured that the vessels that we seal will stay intact. And you have to keep in mind that this patient had a lot of chemotherapy, a lot of steroids on a regular basis, even now getting. And dexamethasone is going to disrupt the collagen. So you have to keep that thing in mind. And you may seal the vessel. If the vessel is not elastic enough, it's probably going to reopen. So there are lots of concepts you have to keep in mind and not necessarily jump and say, hey, I know how to loop a polyp or how to cut a polyp and cut it. Dr. Graham, any other thoughts?
No,
All right. Yeah, so I'll actually give you a feedback on this patient.
oh, did you take out the other little polyp?
She has the rest of the colon cleared out. Actually, the other little polyp that you saw was already taken out before she came to see me. So I cleared her a few polyps on the left side. They were small. The reason I did that was, if in case she goes for any definitive procedure, so at least we will spare her from another procedure in a few months. All right.
Well, the good workman understands his tools.
Yeah, it's a tough problem. Actually, it's a tough problem. I felt sorry for putting her through that procedure. That's why I keep thinking, we are in 21st century, and there is so much of video available, but we can't record a video to help others make better plans.
It means you need to learn ASD.
Huh?
You need to learn to do the ESD also.
Yeah, I think you're right, but I'm glad that we have at least 2 or 3 people in Houston who do a good job. Mohammed Atman at your place does a great job, and I'm glad that we were able to recruit Philip G, who does a good job. I believe there's somebody at Methodist. To me, the way I look at it is the number of times we need people doing ESD is small. If most of us could take care of the regular polyps well, that's good.
There's more than you can do as it is with what you do.
Right. Thank you, sir. Sylvia, may I request you to summarize? I think with take-home message, I think it will be good. It's important for people to appreciate that, at the end of the day, we need to keep our patients safe.
Of course, that's the most important take home. I will try to summarize using the problem-solving conceptual framework. I don't know if Roy is with us. I would appreciate your help, Roy. So the problem-solving conceptual framework is what the experts use to solve a difficult problem. And it consists of the following steps. First, describe the context, then the key features of the case, then compare with previous experience and learnings from the past, and in the end, narrow down the solutions to end up with the best solution for your case. So regarding this very challenging case, the context is, of course, referral for endoscopic resection of a large polyp, large colorectal polyp. The key features of this case, patient-related features, are 70-year-old lady with complex medical history, multiple myeloma, for which she's on active therapy, including corticosteroids, immunosuppressive drugs, and autologous stem cell transplant. Also, multiple abdominal surgeries, cholecystectomy, I recall, appendectomy, hysterectomy, and also diverticular disease complicated with diverticulitis, so also abdominal problems. And regarding the polyp-related key features, we encountered a large pedunculated or semi-pedunculated polyp, a multilobular lesion with a thick stalk, which definitely contains several blood vessels, and resection of such lesion is associated with a high risk of bleeding. Next step, we compared with the previous cases we discussed about EMR of large pedunculated polyps. I think we have covered quite a lot of similar cases, but not in this context, not in a patient with so many comorbidities. And the last step, narrow down the solutions. We listed actually all possible solutions we have previously discussed about resection of such polyp using endoloops, resection using after injection of the base of the lesion, using hot snare, and then clipping of the defect. In real world, we have learned that this procedure remains still a very high risk procedure for complications in a frail patient. The lesion was proximally located, so in case of rebleeding, the access to the lesion was not to be easy, and also given the previous abdominal surgery in this case. So cumulatively, there were several risk factors for complications, and a good discussion with the patient before could not anticipate the real life situation. So in this case, the best solution was to refrain from EMR and to discuss with the patient the alternatives, which would be in this case surgery or ESD, as you already mentioned. And again, in these cases, it helps always to have a good advice from your oncologist or hematologist regarding the lifespan of the patient. I think based on the literature, they could tell you, well, in this case, the patient, the life expectancy would be longer than 5 years. And because this lesion could grow to cancer in 5 years, the decision was to resect it. But again, the safety of the patient goes first. So that was the best decision, I think.
Thank you so much, Sylvia. That is really fantastic. You know, after listening to your summaries, my notes are getting actually better for my patients. So
thank you
thank
all.
you so much.
I have learned a lot from you all.
All right. I want to thank everybody. I want to thank Sylvia, Selvi, Ravi, Nizam, Zubair, Dr. Graham, Jaydish, John, Paolo. Thank you so much. Hope you all have a nice weekend. Take care. Bye-bye.
Thank you.
Thanks, everyone. Bye-bye.
Have a good weekend.
Thank you.
Bye-bye. Thanks
You.
a lot.
Bye.